My name's Robert Zigmund.
I'm Michael Glazier.
And we did case study 18, Julia. So the case study went over Julia's life from childhood through high school and college. Through childhood and high school, she was somewhat concerned about not reaching her full potential, and her family wasn't overly intimate. She was teased as a child a lot about baby fat, and that made her self-conscious. She was made fun of several times for being what people called her a goody two-shoes. Her mother would always check all of her assignments, and this made her feel not trusted. Her mother would always go over and say, "Did you do your work? But then I want to check to make sure it's good quality." And then she wasn't really allowed to go out with anybody when she wasn't in a group, so she didn't really date much, and it created somewhat of a rift in trust through childhood and through high school. In college, a lot of the stress increased, probably due to work, but also due to those self-conscious feelings that she had from earlier on in her life. She had trouble keeping up with her teammates when she was running on cross country, and this made her feel even more self-conscious. She wanted to lose weight to improve her performance, but she was within the normal weight range, so she started not only getting rid of snacks and sweets, which the coach had recommended to her, but she also started cutting out whole meals entirely. And one of the first meals she got rid of was breakfast. She thought, if I don't eat breakfast, that'll accelerate my weight loss. But then she started going down a path even further. The mother became concerned because she looked so thin. She had resorted to only really eating carrots and other vegetables. The mother called the coach, and Julia became concerned that she would have to go to Thanksgiving and eat in front of her family, and she didn't want to do that and eat fatty foods as she viewed them. Her roommate noticed that she was only really eating vegetables and foods that didn't really have any caloric value whatsoever, and also became concerned. So her mother sent a message to Julia's roommate, and the roommate expressed that concern again. And then the dean came and said, if you want to compete on cross country, you're going to have to go to a health center evaluation, and until that's done, you won't be able to play on the team or anything like that. That made Julia upset, and that's where the case study really ends. So going off of that, we were able to make a diagnosis of Julia for anorexia nervosa restricting type. She meets the DSM-5 criteria, which we'll cover in a later slide, but she lowered her food intake significantly, even though her weight was within the normal range. So she actually created a substantial weight decline when there may not have been a need for a substantial weight decline. She went from 145 to 115 in a very short period of time. And then she continuously exercised excessively, in addition to that extreme dieting, which further caused her weight to plummet. And then she had, all of this was around an anxiety over her weight when she would go to meets for cross country. She felt like people were looking at her. She didn't feel that her body was right, whatever her perception of that was. So whenever people were concerned about the way that she looked, or they said that she looked too thin, she became just more anxious about the way she looked and started wearing baggy clothes, because she figured, well, maybe I'm not overweight, but there's definitely something wrong with me, so nobody should have to look at me. But it was still an obsession with the weight. And then one note here is that it is restricting type for Julia, because she did not have binge or purge episodes, and she focused really intensely on excessive diet and exercise. So for the DSM-5 criteria, she meets almost everything that's required for anorexia nervosa. So for section A, she does have a significant decrease in her energy intake for food, and it's definitely different than what is expected for somebody in her height and age range. So that criteria is met almost immediately once we look at the case study. For criterion B, she did have a fear of gaining weight. She didn't want to gain any weight at all. She wanted to lose it. She thought she was already overweight substantially, and she wanted to get rid of any weight on her body. And for criterion C, she did meet that because she continually expressed feeling that people shouldn't have to look at her, there was something wrong, and that she wasn't really the ideal type, whatever that would be in her mind. So this is just the next section of DSM-5 criteria, the two specifiers, restricting type and binge eating type. So for restricting type, Julia is only the restricting type because she focused on limiting her food intake. She did not have an episodic way of approaching weight loss, where she would binge and purge. She didn't do that. Instead, she really curtailed her caloric intake to where it was a very unhealthy level. So these are just some statistics about anorexia nervosa. A little bit over 0.5% are affected. Girls are 3 times more likely to be diagnosed than males. Of course, this could be attributable to less likelihood for men to come forward and somewhat of a stigma around the disorder, but that is the current statistic. Unfortunately, only a little bit over 1/3 of those people with the disorder actually receive treatment. The average age of onset is around 19, but some studies are showing that the age of onset might be decreasing, and that means anorexia is developing at a younger age. Causes, there haven't been really any pinpoint causes of what is creating that possible decline in the age of onset. And anorexia has a relatively high mortality rate compared to those individuals who do not suffer from the disorder and other psychological disorders altogether. So that is something of concern for treatment. So we believe that Julia might have major depressive disorder in addition to anorexia nervosa restricting type. For criterion 1 of major depressive disorder, her friends noticed that she didn't really ever talk much, and she appeared withdrawn during any social interactions. And this was even before the anorexic symptoms started to set in. And the roommate perceived this as shyness, but it doesn't appear to ever go away in the roommate's story about Julia. In criterion 2, she really competes in cross country a lot, but she doesn't really seem to get much pleasure out of it other than the exercise. She doesn't seem to view it much as a social activity. In fact, there was a lot of anxiety when she was going to cross-country meets that she wasn't performing as well as she should have. She's not really involved in any other activities. Criterion 3, while this isn't fully able to be attributed to major depressive disorder because she was actively dieting, the level of weight loss is substantially different than what a normal diet would be. Criterion 7, she expressed a lack of intimacy in her family and feelings of inadequacy. She didn't really feel trusted. She didn't feel good enough. And in college, she started saying that the stress she was feeling for criterion 8 must have been attributed to something college-related or normal for a college student, but the level of anxiety and distress that she was explaining were not within the normal range. And then her symptoms really caused a significant amount of difficulty in social settings because she tries to avoid them completely later on in the case study. She stopped spending any time with her friends, and the reactions that fit this area of major depressive disorder are really not attributable in any way to solely anorexia nervosa. And then these are just some of the other diagnoses we considered for the disorder that didn't fit. So the first one obviously is bulimia, but she didn't fit bulimia because she did not have binge eating episodes, and her disorder was not episodic, so it was consistent. And her weight was significant, which is similar to bulimia. She had a significant issue with the way that she felt about her weight, but the lack of binging and purging is enough to rule out bulimia entirely. Obsessive compulsive disorder, although her excessive restriction of food intake and her extreme exercise habits could be considered a compulsion based off of obsession with weight, anorexia nervosa more clearly encapsulates all of the symptoms that she had, and it is very specific to what she was experiencing. And then the third one is the reason we did not pick the binge eating specifier for anorexia is because she did not binge and purge.
All right. So her treatment goals are broken down into immediate, short-term, and long-term goals. For immediate goals, the main one is to establish trust and foster openness. The main thing is at the end of her case study, essentially, she did not want to receive any form of treatment, and she didn't see the need to at all change her lifestyle. So people were kind of forcing this on her. So it's very important that as a psychologist or as someone trying to treat her, that you do not antagonize her. Number two is help her realize her behavior is harmful and create a desire for change. So essentially, she doesn't even see the fact that she is significantly underweight as at all harmful to herself or causing any other types of issues. So it may very well be that she finds so much stress and is having all these other problems in her life due to the fact that she is not getting enough calories in her diet. So the short-term goals, after we're able to do that and create a desire for change, the first things we want to do is establish a healthy body ideal and incrementally raise caloric intake, which is pretty self-explanatory. Number two, participation in social activities. So as she started to restrict her diet, she very much started to not hang out around her friends anymore because they used to want her to eat more or felt strange about her eating habits. There were times where she would just cut up a cracker into 4 pieces and eat it every 15 minutes. So people thought this was very strange and they started to really get on her back for it. So she just started to eliminate social interactions altogether for breakfast, lunch, dinner. And she really wouldn't see people at all. And this is unhealthy, causing her stress. It's very important for people to have some form of social life. And this also is a way of keeping her diet regulated. Number three is creating a regulated eating schedule. If you don't eat in the morning, you're more likely to be hungry later in the day, and you're likely to have more emotional fluctuations. And just having a regulated eating schedule is much easier to fit those calories into a meal and have her not feel like she's overeating in one meal and trying to fit it all in. Long-term goals is body acceptance. She needs to be at a healthy weight and accept her body and not feel that she's uncomfortable with that. Most likely, she wants to be very good at her track meets and things like that. So essentially, she needs to be a little bit higher weight. She at first saw benefits by losing weight and seeing her times go up by being lighter. However, this will not maximize her output. And by having her notice this, she more likely is able to have a body weight which is ideal. Incorporate proper macronutrient ratios into diet. So essentially, she would only eat vegetables, and that is not particularly healthy. So she definitely needs to incorporate some protein into her diet and some fats into her diet. So that is one of the long-term goals because this can be very hard for her to cope with at first. She definitely needs to feel the desire to go about changes first and not force her into anything. Create healthy relationships. So when she starts regularly having social interactions, she now has to have healthy ones and more regulated. Having a healthy coping mechanisms for stress. She, at the end of the case study, was never seeing her friends, was studying all the time, and felt she could never keep up with her schoolwork. She was always stressed out, and she would eat even less because of this, because she thought it would make her feel better. So this needed to change. So the treatment plan, overall, we incorporated the majority of therapies. We incorporated exposure therapy, cognitive and behavioral exercises, journaling, and group therapy. Mainly, this was due to the fact that we don't know how she will react to any one kind of treatment we try to give her. So the main point is that we adjust slowly to her pace and not try to force anything on her and antagonize her. The estimated length of therapy is 4 months. Due to the nature of relapse, it is important to make sure the client has regular follow-ups. So treatment session 1. The first thing we want her to do is vocally relay the events leading up to her seeing a psychologist. When someone is able to tell the story and hear it, a lot of times they can start to see things from a different perspective. So venting tends to be a very good way of depersonalizing it. And if she sees it from another perspective, she may think, okay, maybe being significantly underweight and this whole process I've gone through, I didn't realize it before, but now maybe might not be so healthy. And then we should have her describe her body ideal. Does she want to be 100 pounds? Does she want to have absolutely no fat on her? Does she want to reach a certain BMI? We need to establish what exactly her goal is, because she may have not already had an established goal. Next is write a list of her intended goals from dieting, and then question the validity of those goals. So one example would be, I want to be thin so I'll make friends and be accepted. This was a large part of it at the beginning. She felt that she was a little overweight, such that her track friends didn't really accept her, and she wasn't really invited to parties, and people didn't really like her. And she thought that being thin would make her beautiful, make her more liked. However, what happened is, as she started dieting more and more, she started to actually lose friends. She started to So being very thin will make you a better long distance runner. However, being emaciated will lower your energy levels, reduce muscle output, and slow your recovery time. So these are just two examples, but there may be other reasons why she would want to diet. So we should also just go along with the logical reasoning and see if these are actually true. And it tends to be that this level of body fat and this level of caloric intake is not healthy in any way. We show her images of others suffering from anorexia at different weights to see if she finds them ideal. So essentially, we do not want her to look at herself and think that she is fat or anything like that, right? But no matter what, if she looks at herself, she can be a stick and still think that she needs to lose weight. However, when you look at somebody else, you can very well see that this person looks emaciated or this person doesn't look healthy. So you can see somebody at a healthy body weight, see somebody at an emaciated body weight. And you can very clearly tell that this is not healthy. However, when it's yourself, it's very hard to step back and see it outside there. So then she can now have a more healthy body image of what isn't ideal. And do not make her change her lifestyle. So we cannot, at this first session, force her to do anything to change. Right now, she's still unwilling to really do anything. So she has to come to this decision without being coerced. So the first assignment is essentially just reading about anorexia. Now that we've shown her all these other images of people, shown her essentially the criteria of anorexia, told her about the negative aspects of it. Now she just read on her own and see if she might consider that she may actually have a problem. All right, treatment session 2 is ask her about her anxiety levels, energy levels, eating and exercise schedule. So this is part of the foster openness that we established before. What we want is for her to be very open and to be able to talk about her issues. We don't want her to feel like we are trying to antagonize her or change her in a way that she does not want to be changed. And then we have to speak about the health effects of poor nutrition. So continue on this process that we're going before. So we're still trying to get her to want to change. So we're not even trying to make her change yet. So it's really important because there's a chance of relapse. We don't want her to feel that she's doing this for someone else. And then attempt to consolidate acceptance of the unhealthy eating habits. And then create desire to take a small step to change. So still, just create the desire. We don't have to make her make any changes yet. Do not create anxiety by radically changing her lifestyle, eating habits, and looks. Right? And the main assignment this time is to keep a food journal and her associate emotions with those foods. So if she eats one food, she eats a carrot, she feels good. Or if she eats a very small meal, she feels good. Just to have her start thinking about her emotions, because she started to think about her hunger pains as badges of honor. So she has to start seeing that these pains aren't necessarily healthy, and the associated emotions that come along with them because she got so used to ignoring them. All right, sessions 3 through 5. This is where we start actually trying to implement the change. So what we have her do is we have her talk about changes that have gone in her life as well as emotional struggles. So we still have to create some openness and see if any new variables came into the scenario. Incrementally increase caloric intake. So she may be eating 800 calories a day right now. So maybe she's willing to go up to 850. Maybe she's only willing to go up to 810. The point is just a very, very small increments that we increase her caloric intake. So just as small as possible, such that she's willing to make a change and move in a direction. So the main thing we want her to do is start eating socially for lunch. We may not have this done by the 3rd session, we may not have it done by the 5th session, but the point is that this is the next goal. So we have her do this by essentially just contemplating this, thinking about it, and we realized before she wanted to have a social life. This is her desire, but so this is one way to start having a social life and putting herself out there. And then monitoring changes in athletic performance. As she raises her caloric intake, most likely her athletic performance will increase. For a period of time, as she was losing weight, her athletic performance increased. But now, by increasing her calories, she likely has more energy output and is likely able to recover faster and put on more muscle. So that would likely make her a better racer and give her more impetus towards increasing her calories. So this assignment for these 3-5 weeks, as we see how she changes, is to add to journaling her stress and her coping mechanisms. Times she feels noticeably hungry, considering she learned to completely ignore this and see it as somewhat good. So now she has to focus on the negative aspects that this is causing to her life, and her feelings about going through therapy. Because it may be that her feelings fluctuate about this. Maybe one day she's like, okay, I'm going to lose weight, I'm going to gain weight, and I'm happy about this. And then one day she feels terrible about her body and she wants to lose a bunch of weight and she doesn't feel like eating at all. So it's important to see how she feels about therapy and how she feels about changing on a day-to-day basis, because this could fluctuate regularly. Sessions 6 through 9. So at this point, we're hoping that her athletic performance improves enough that she sees it as viable to continue down this path. And also, she should start to have moved in a direction where she's actually implementing a change. So we start incorporating cognitive therapy and having her visualize eating more food groups. We don't want to pressure her into actually doing this. We just want to have her go through this thought process, imagine it, and then understand the emotions that come up, and not necessarily have her face them, but just have her regularly come across these such that she is now acclimated to this concept. And then we have to have her regularly imagine an ideal social life and an ideal body. So by session 6, we'd like to have her start eating breakfast, not necessarily a big breakfast, the smallest, just keep slowly acclimating. And then by session 7, we start eating breakfast socially. And then session 8, start eating dinner. Session 9, start eating dinner socially. So at this point, when you eat dinner socially, it creates a social life and also has her eat a bit more, hopefully. Once again, she may not necessarily move at this rate, but this is our intended rate. And then she should still keep a journal tracking her diet and emotions about food, as well as her social life interactions. So no essentially new journal or assignments that we want her to do unless something comes up where she's not following this progress pattern. Okay, sessions 9 through recovery. So each session, we should hopefully start incorporating a new food group into the diet. And what we want to do is just incorporate the bare minimum of this. Let's say she won't eat oil, or she's not willing to eat protein. What we do is just, after these weeks of going through these cognitive exercises, we have to start incorporating behavior. So we need to just have the smallest amount that she's willing to take. Maybe she's willing to have a tiny piece of chicken or a tiny piece of avocado at a meal. That's enough that's now creating a change, and now she can start to build off of that. But it's important not to jar her too much. She needs to be able to feel that she's in control, and this is what she wants. And if you all of a sudden create a radical change, it's a high chance of her relapsing. And then, at this point, hopefully later on in the recovery, by session 12, 13, considering you can gain weight relatively fast, now you need to create a caloric intake to maintain body weight. So now that she's hopefully within a healthy range of fat, body fat index, she's able to maintain that and then not gain or lose too much weight such that her emotions go out of whack. Continuing with journaling, and now she adds her emotions such that we're able to track her stress and her body perception. And by this point, she should have healthy social interactions. If she doesn't, that's meant to be dealt with. If we still see signs of major depression, we're going to deal with that in whatever way we see fit. But ideally, this should be the course of recovery. So other treatments considered an obstacles. Due to the possibility of her being resistant to multiple parts of this therapy and her maybe not even wanting to go through therapy, we kind of incorporated all of these. So she should go through group therapies at certain times. If she's really doesn't see herself as having body weight issues, then group therapy may be helpful to see other people. The main obstacles, though, are her not journaling, her skipping meals, her lying about her progress, not desiring to change, and her relapsing and not coming back to therapy. So relapsing and not coming back to therapy is able to be avoided because she needs to do this for her track team, and she seems to desire to keep on that very much. Skipping meals, we can kind of see that by her body weight. And journaling, journaling we check at the therapy sessions whenever she comes in, and we can see that. Lying about her progress, that one's a bit hard to tell, but hopefully between the journals and the weighing, we can tell. And then not desiring to change, considering that is focused on so early on, and that is the only purpose of the first 2 sessions, and maybe the 3rd and 4th or 5th, as long as it takes to consolidate that. We can sort of see that by talking to her and sort of changing how we approach this. Contingency plans. If primary strategy doesn't work, obviously we have to adjust. So I already said a bunch of the adjustments that we may have to do, and the point is not to force her to progress at the expected rate. We have to reevaluate the situations and determine where she finds difficulty, but the main point is that she is not coerced.
So for the prognosis, if she is able to successfully complete therapy, it's likely that she will make a full recovery, but there is around a 30% chance for a partial or full relapse. 70% of people with anorexia do not relapse at all, but that is something we'll want to be monitoring. So the length of treatment and the duration of the disorder have been found to be factors into whether or not a relapse takes place. So it appears that it is essential that we have very quick response, which in this case, it seems it's relatively fast. It didn't take like a year or 2 years to acknowledge the anorexia. So in order to prevent the threat of a relapse, it's important that even after recovery, we follow up semi-regularly with Julia to make sure that she's continuing to make progress. These are citations.